In kicking off our event with our first speaker, it is my pleasure to introduce Andrew Bastrous with Peak Vision. Andrew is an ophthalmologist and associate professor in international eye health at the London School of Hygiene and Tropical Medicine and co-founder and CEO of Peak Vision. He has worked and undertaken research in over 20 countries, including 2 years living in Kenya, where he was leading a major eye disease study and developing and testing the earliest versions of Peak's smartphone-based eye health system. In addition to being a masterful storyteller, Andrew's passion for using technology and locally derived interventions as a step towards achieving universal healthcare drew us to his story. In his keynote, he'll explain how his own personal challenges with eyesight drove him to a lifelong career in improving the vision among the least served populations. Welcome, Andrew.
Thank you very much for inviting me to speak at this fantastic conference. I want to begin by sharing the story of a lady called Fatuma, who I had the privilege of meeting when I was living and working in Kenya. Fatuma had approached an eye clinic we'd been working at, and she came to see us at the end of the day as we were packing away our equipment. And she came with her clothes were ripped, she was swaddling a young baby, and she looked very, very stressed, and she looked like she was probably in her late 20s. She sat down at the slit lamp, which was the device I was looking to get a close-up view of her eyes, and I saw a familiar sight, which was that rather than her pupils being clear, they were both white and blocking all of the light into her eyes, and she was completely blind. I asked her when she thinks she could last see, and she had memories of being able to see from when she was about 4 years old. That meant that even if we did surgery to remove the cataracts, which were those white elements of her pupils, there was a high chance she would still not go on to see, but she was willing to try. The mix of emotion when I met Fatuma was one of great hope that we could transform her life with a simple operation that could be done in 10 minutes tomorrow, but equally maybe we were too late and she'd missed her chance. Fatuma's story isn't unique. She is one of 1.1 billion people on the planet today who cannot see as well as they could. There have been some recent landmark papers by the World Health Organization and the Lancet Global Health Commission on eye health. And in summary, what they show is that of the almost 8 billion people on the planet today, well over 2 billion have an eye need today, of which half of which has yet to be addressed, so over 1 billion people. And the absolute majority of those over 1 billion people have very treatable conditions, so they would be treated with a pair of simple glasses, a 700-year-old invention, or cataract surgery, one of the most cost-effective and quick surgical procedures in the world. Despite 90% having curable conditions for which we know the treatment, they're still not getting access to those services. What's more, the global population is growing and aging, and with that will come an increase in the numbers unless we drastically change what we're doing. Some of the reasons behind that are around how healthcare is inequitably distributed. So this is something called a density equalizing cartogram. It's basically a map that has been distorted, and you can see sub-Saharan Africa and Asia here look swollen, and they're showing where the prevalence of blindness is greatest based on 2010-11 figures. Whereas when you look at where ophthalmologists, so the eye surgeons who are providing much of this treatment, are distributed, it's inversely proportional to where the need is. And you can see particularly sub-Saharan Africa here shrinks to being incredibly small. Just to give you a sense of this in terms of numbers, for every ophthalmologist in the UK, so for every 75 of them, there's 2 in Kenya, working for a not dissimilar sized population across the country. That's further compounded that there's few ophthalmologists, so approximately 100 in Kenya, are not equally distributed across the country as we see in every country in the world. So around half, 50%, are based in Nairobi, which serves about 8% of the country's population. And as you go to the remote rural parts of the country, there can be a single surgeon responsible for a population of sometimes between 3 to 5 million people. Now, I came into this whole field through myself being having very poor sight. So, I grew up with seeing a very blurred blackboard. Faces always looked without detail, but I didn't know that was not normal. I grew up with that as my state of normal. And as years went by, I was told recurrently by my teachers that I was not paying attention, I wasn't performing well. And I just assumed that was what they were saying of every child. To my surprise, at the age of 12, I actually got my first pair of glasses, and both the optometrists, the teachers, and my parents were shocked. And this was me in my first pair of glasses. But the world changed overnight. I went from not being able to see the blackboard, not knowing that trees had these clear leaves on them, not seeing stars in the sky, and not performing at school, to suddenly doing well at school and having a completely different potential future ahead of me because of a really simple intervention that no one knew that I needed, and I didn't know that I needed. And growing up in the UK, I was struck the same year I got my glasses, where I was visiting Egypt, where both of my parents are from, and we would regularly return to as a child, that many, many people were not wearing glasses. And this got me thinking. This was further compounded by a visit to a place in Cairo where all the rubbish is basically stored and managed, and seeing a young child there who looked so similar to me, and just thinking, the world you're growing up in is so different to mine, and it just felt so deeply unfair that it really got me questioning these things like glasses that I'd got. What else am I getting that I don't even have to think about, that I'm getting access to, that in so many parts of the world is not even possible? And really from that point on, my journey began trying to understand why this problem existed and why I happened to be on the fortunate side of the equation. Many years later, this took me to training as a doctor, becoming an ophthalmologist, and then taking my family and leaving my career in the UK to set up a large program in Kenya. And this is my wife and our 1-year-old son almost 10 years ago when we first made that move. And I was doing a PhD with the London School of Hygiene and Tropical Medicine, where I continue to work at the International Centre for Eye Health. And we established 100 temporary eye clinics across the country. And we were doing a very large study to really understand what the unmet need was and what the barriers were, and how big the problem was and what could potentially be done about it. This involved us setting up clinics in all sorts of remote locations, such as this school here, where this photo was taken from was as close as we could access with our 2 vehicles. So a team of 15 people had to carry over £100,000 worth of equipment for almost 2 hours just to be able to get to the clinic. And that just gives you a small sense of how difficult it is for people in the community to access services, when that was us taking services to the community. When there was road access, we were often, particularly in the rainy season, would really struggle to get to where we were going. But when we did get there, we were using state-of-the-art equipment to provide really comprehensive, detailed assessments and understand people's needs. But rarely did we have power supply. In 70 to 80% of the clinics that we ran, we'd have to use petrol-powered generators to run our equipment. But in every clinic, every place that we went, there was consistently long queues of people waiting to see us, many of whom had very treatable conditions and had been living for a long time with a vision impairment or pain in the eyes that was manageable. And we would see the compounding effect of people having lost their sight. That in this photo you see 2 young children near their grandparents who are not in school on a school day because they're providing care to their parents or grandparents. And so the ripple effect of sight loss is it goes beyond the individual, and it goes into their family and their community. And at one of these clinics, I remember this moment where we'd struggled to get there. There'd been no roads, there was no electricity, there was no running water, And I went to use this pit latrine, and as I was going to open the door to the pit latrine, an old man came out and was chatting away on his phone. And suddenly it struck me, I'm here in this incredibly remote location with very little infrastructure or access to health services, yet there's access to mobile phone services. And this got me thinking further. And as I looked into it, at that time, more than 80% of people had access to a connected mobile device, whereas only 50% had access to clean running water. M-Pesa was really growing at the time, and now provides more than half of Kenya's GDP via M-Pesa transfers, and is a huge success in terms of how the financial industry has empowered people to engage in the financial market. What's more, technology has moved in a way that I don't think we could have fathomed. This is just over 50 years ago, so not that long ago. This was a 5 megabyte hard drive. A computer that put a man on the moon just over 50 years ago, that filled a huge room, was 300 times less powerful computationally than the first iPhone that came out 14 years ago. So the world has moved in a really rapid way, and this was really this connection of huge unmet need, disproportional access to the services, yet access to high computational power and potential that was the inspiration behind Peak. And Peak was really designed to try and bring together the advances in technology to try and connect and access those who currently were being left behind. One of the first things we developed was a vision test, which was designed to run on a phone so that any examiner could hold a phone and swipe the test without having to have an eye health background or a clinical background, just needing to be able to operate a phone. And we tested this in the hands of community workers, volunteers, school leavers, nurses, and we found that it worked really robustly in a trial where we validated it against the reference standard. And we found it to be faster than the standard, as accurate, and much easier to use. We subsequently released it on the Google Play Store. It's globally available for free. It's been used in 190 countries today. Beyond that, we started to think, well, what are the applications for this? How do we start to really increase access? And a fantastic colleague of mine that you can see up here, Dr. Hilary Rono, who's one of these ophthalmologists who is serving a large population, over 2 million people, as the only ophthalmologist for that region. And he sat down with me once over a cup of coffee and was explaining the dilemma he had, that in the schools around him, he knew that many children couldn't see because he'd been asking one of his nurses on his team to go to the schools and provide screening and assessment. And when she would go, she would typically find 5 to 10% of the children having some kind of eye health problem that could be treated. But it also meant 90% of the assessments she was doing were children who were normal, and the clinic she was leaving was always really busy. So he couldn't justify her going, yet he was very uncomfortable knowing so many people in the community couldn't see. And this struck a chord with me, with my own experience of having grown up with very poor vision, and how if someone hadn't realised this and changed the course of my life, then things would have looked very different for me, and how many other children in Dr. Rono's community were in a similar position. So we started to see if we could enable school teachers to provide vision screening, with the hope that maybe they could find the 5 to 10%, and that very busy nurse could only go and see those, therefore 10 times to 20 times greater efficiency for that very limited expert human resource. And what we found was teachers could very accurately measure children's vision in the school in a very short space of time. And here you can see an example of a teacher measuring a young boy's sight here, and he just asks the child to point in the direction that the E is pointing, then he swipes on the screen accordingly. Some of the advantages here are no one knows whether that child is passing or failing, and the examiner doesn't know, so it makes the test completely objective. You can see the children in the background are watching the test. No child likes to fail in front of their peers, and on a standard chart people can see how you're performing, And plus, if you're clever, you can cheat the test by remembering from one eye to the next, or learning the letters as you go in. Here, this removes all of that subjectivity of the test. We also realised that that once the test was done, the score didn't mean anything to the teacher. And so we built a vision simulation that showed the teacher in real time what that child could see. And that would often be a real penny drop moment. They would understand the visual world of the person they just examined. And that child would go from being the child that wasn't paying attention or was not very smart to suddenly a child with potential who couldn't see. And that was my story as a child. I was that child who couldn't see, but no one realised, but I had no way of being able to articulate this. But we soon realised it was not the child or the teacher who made the decision, once detected, for them to go and access treatment. And so we would take a little Bluetooth printer and print a little photo message about their referral details and what to do. And what's more, we built a back-end system that after the vision test was completed, it would automate a personalised SMS to the parents saying your child had been found on this day, this is where they needed to go and what they needed to do. The hospital who was receiving patients would also receive notifications, so they knew how many people were due to come, and then there started to be this closed loop of an understanding of the demand being generated and the supply capacity to meet it. We also looked at who were influencers in this system, and we found head teachers were powerful influencers in that they knew all of their children in their school, and it turns out they were very competitive, as you can see by this large trophy on this head teacher's desk. And they wanted to know how their children had the potential to perform better in terms of their education, and this, therefore, when we sent them messages telling them how their school was performing in terms of the number of children found adhering to their referral compared to the neighbouring schools, would often jolt them into activity to bring more children to the school. We initially ran this as a randomised controlled trial which included 21,000 children, of whom 900 were vision impaired, and this was conducted by 25 teachers in 9 days. We realised at this point we had a potentially scalable system for which we had evidence that worked, and the key data that was arising was we were understanding the prevalence of problems in the community. We were able to identify those individuals and connect them to the service. Critically, we were also able to know how many people were not making the service, so who was being left behind, and of those who were making the service, how many were appropriate or inappropriate referrals, so a quality assurance loop. And that work was published in the Lancet Global Health. It then went on to scale to cover the entire county, covering around 200,000 children across 400 schools. And we replicated that program in Botswana, where we piggybacked a HPV vaccination program. So the nurses delivering vaccines were also trained to deliver vision screening. Now, interestingly, in Botswana, the geography and landscape is very different, and it's a small population in a large landmass. And so often the distances between the individuals and the hospitals are so big that they can't be reached. And so in this program, for around every 6 schools screened, a team from the hospital would go and provide triage services. So they would go and meet all the basic eye care needs that they could, provide basic glasses, and only onward refer those who had a complex condition, meaning around 90% of services could be actually delivered closer to home in a cost-effective manner for the service provider. The program in Botswana was a huge success and enabled us to really advocate for this program at the highest level. So here you can see the President Masisi, flanked by the Ministers of Health and Ministers of Education. And using this data and advocacy, they were able to make a commitment to provide eye screening and services to all school children in the country. A further conducted trial in India by my colleague Dr. Priya Morjaria followed the same process that we had in Botswana, but also went one step further to see, of those who had received the service, 3 months later, how many had actually been impacted, specifically focusing here on children being given glasses. And so here we found that 50% of those given glasses 3 months later were not wearing them for a variety of reasons, many of them psychosocial or cultural, but were critical to understand how impactful was the program in reality. And from this, we were able to really start to understand the journey to impact, from being invisible and having this unmet need, to being found, to being diagnosed, to reaching a service, and then to knowing if that service worked. And why that is critical is ultimately in any program or any intervention, we have an expectation of how well it will work. So in this example here, if there are 5 people with an unmet need, we provide an intervention and we expect that they'll all come out with their need having been met. But in reality, what happens is only some of them get the outcome that we're hoping for. But the interventions are large, they're complex, and we don't know really what's going on in between, so we tend to repeat the mistakes of the past. And all systems leak, so it's incredibly challenging, and the environments we work in are complex, and there are multiple relationships and stakeholders. And so what we're trying to do now is just make sure that reality can be seen and therefore it can be accountable. And this means we can start to see who is falling out and ask the question why. And by asking the question why, local solutions to the barriers for people like Fatuma, who'd spent so long unnecessarily without access to services, can be resolved. And the approach we take is a population-based approach that is person-centred. So with any population, there are those who have no need, there are those with an unmet need, who are the ones who are in red here, and those who've had their need already met, so such as me wearing my glasses. Now, this could apply to anything in public health. It doesn't specifically have to be eye health, but this paradigm is a powerful one in terms of delivering equitable, effective coverage. And so the approach we take is focusing on those who have an unmet need today. So of 100% of all of those with an unmet need, we want to know how many of them have been identified. So what's the coverage of identification, whether that's through a screening program or sensitizing people to come to the first line of the service. Of those who've been identified with a problem, what proportion then make it to the services? And in this example, 50% have made it. Typically, we see this can be as low as 10% making the service. And then of those who reach treatment, for how many does it actually work? And in this example, where the intervention is very effective, 75% working, you can still see the outcome here. From 100 with a need, only 30 are achieving the outcome. Now, we don't typically see this data because programs focus on activities rather than outcomes. So you could be fooled into thinking that a program was very robust because of the high volume of screening or high volume of treatment. But unless we're asking the question, who did we not even find? Who did we find but they didn't even reach treatment? Or who had treatment but it didn't work? Then we don't actually know the full picture. And in this example, if we look at those who are falling out of the system, we can start to see what's different about those who are making it through versus those who are not. What are the barriers? Things such as gender, the age, the location, socioeconomic factors. And we do this through a connected data system because we're able to see the patient journey through the system and therefore start to be able to respond to it. So in this example where 50% are not making it to the services, we start to ask the question, why are they not doing that? And we do that through community participation, trying to really understand the barriers from those who are facing them. And we've realised over time there's a range of different barriers to access that could be considered in A, B, C, D, E, F as a paradigm. So awareness, bad services, so by that in terms of having to wait long times to be seen or not having clarity around what options are available, the costs, both direct and indirect, the distance, the escort, needing an escort, so somebody to come with you, fear and gender disproportionately affecting women and girls more than men and boys. Furthermore, when we look at specific examples of this here, this is one that happened whilst I was living in Kenya, that we were offering free surgery and free transport, yet 50% of people still were not coming. And it turned out the reason why was the word that was being used for surgery in the local dialect didn't translate as surgery, it translated as butchery. So they were hearing, we're going to provide transport and a free service, and then we're going to butcher your eye. So it was no surprise that so many people didn't take it. The change of a single word doubled the number of people coming. So rather than 50% coming, or 50% not coming, that halved down to 75% of those being offered services started to come. And that was by the change of the word. So the role of technology here was not to solve the problem, but identify where the problem was, and then the community solved the problem. And what that looks like in practice is, rather than 50% making it turned, as I said, to 75%, and that translates to, rather than 40 receiving treatment, 60 do, and rather than 30 getting the desired outcome, 45. So we're getting this 50% increase in impact through a small intervention at the right point in the system. And so our learning has grown from programs that initially started in as trials or pilots in Botswana, Kenya and India. And since then, we've gone on to develop Peak Solutions. So Peak Solutions is really a package of products and services to enable our partners in low and middle income countries to run these programs that give them a range of tools. It includes the visual acuity test that I mentioned before, but a whole range of configurable options for them to design their program based on the reality of the patient journey. And this helps them really start to visualize and understand the barriers that are being met by different groups throughout the program. Once configured, each user in the system is given a different suite of tools that are tracked by the local administrator, and that local administrator is able to get really rich data in terms of what's going on in real time, to be able to respond to it and really understand the barriers that people are facing in that program. The programs that we're now offering with our partners have started to go beyond those initial countries to also in Zimbabwe and Pakistan, Ghana and Uganda, as well as continuation and expansion in Kenya. And so from those initial programs, we have a range of new partners working in new countries across the world, and many new ones due to launch in the not too distant future. And just to give you an example of the types of things that we're seeing. So here is one of the programs that has been active for some time, and what we're looking at here is this red line is the proportion of those who've been found with a problem making it to the service, so the adherence. And you can see in these sites over 90%, so 9 in 10 people found are getting to the services. But all of these ones are dropping off to that between 10 and 20% type level. And the key difference is these locations are all within walking distance. All of these require some form of transport, and they get progressively further and further away. And what the local team using this data did was say, well, if we start to provide fixed appointments, we can cost effectively also look at doing things like transport or subsidised transport. And the impact of doing that was that in those other locations, once fixed transport was put in, you can see many of them start receiving very, very high adherence. And that's that insight that drives action, provided there's the right stakeholder engagement, partners, attitudes towards funding unknowns prior to them being identified in the planning stage, can really transform the system for those who are in it. And so the programs across are continuing to learn and be responsive around trying to get as many people through that system as possible, so that we can genuinely try and achieve universal health coverage by focusing on those who are being left behind, and focusing on people like Fatuma, whom I mentioned at the beginning, for whom she had been left behind and we didn't know if the services would work for her. In Fatuma's case, we did her cataract surgery, and all of us gathered around the next day hoping that it might work. And to our excitement, when her eye patch came off, she a big beaming smile on her face, and she was delighted. But then all she could do was look at this young 9-month-old baby she was holding in her arms, and just focusing on her child whose face she'd never seen before. And then she said, "I need to get home quickly." And we asked her why the urgency. She said, "I have 2 older children. I've never seen their faces." So we soon took Fatuma and all the others from the clinic back to where we had brought them, and they all walked home except for Fatuma, who just stood there looking despondent, and we asked her why she wasn't going home, and she said, well, I actually don't know where I live. It took me almost 9 hours to find you. I heard a rumour that there was a free eye clinic, and I risked crossing busy roads, and it suddenly made sense as to why she was so stressed. So we spent the next 2 to 3 hours with her trying to find a way to get home, when eventually somebody recognised her, and she said, oh, I know Fatuma, I know where she lives, and she walked us to the edge of her village. And when we got to the edge of her village, Fatuma recognised the sounds, and we walked towards her home. And when she arrived, her husband was there with many children around, and she looked at them and she said, which of these children are mine? And this is the moment she was reunited with her family. And this is ultimately why we're doing what we're doing, so that people like Fatuma who were being left behind are getting access, so universal access to the coverage, to the problems that we know can be solved if there is a collective effort to do so. Thank you very much for taking the time to listen today, and I wish you all the best for the rest of the conference.
Thank you, Andrew, for such a compelling presentation. If you'd like to see more of Andrew's presentations or to hear more about his story, check out the TED Speaker website and search for Andrew's name.